So I think uh, Dr. Raj Bhagat is having some problem joining in. So I'll just give a brief introduction of our chairs till he joins so that we can start in time. Uh, so the Rheumatology Association of Gujarat does an annual conference, and this is called as the RACCon, the Rheumatology Association of Gujarat Conference. And this year, the Rheumatology Association of Gujarat is doing it under the banner of the Immunoallergy Conclave. And what we've planned is to have a 6 months of an online session so as to clear the theoretical aspects of allergy. And then there is a 3-day conference wherein you will have a practical demonstration of allergic practice. So you have workshops on allergy testing and allergy therapeutics, and then you have case-based discussions on in the commonly seen allergic disorders in practice. So continuing with the same sessions, we've had discussions on atopic dermatitis, basic approach to allergy, urticaria, even chronic pruritus, how do you approach to it? And today we have Dr. Vinay Mehta with us. He's an excellent teacher, and I've had the pleasure of listening to him, even meeting him in person in the recent pediatric allergy conference that happened in Delhi. And I think the audience will truly enjoy his presence today. He has tried to make it interactive. So, what he has asked is that all of us who are present here keep our cameras uh, on, and he has some questions that he might ask in the middle just to ensure that there are uh, that all of us are active and alert during his talk. Uh, Asthma is something that most rheumatologists might not manage on their
Mhm.
own. We have an entire specialty of pulmonology, both at an postgraduate and super specialty level, but there is a lot of overlap. So, if you're seeing allergic rhinitis, it is worthwhile to understand what asthmatic management is, because if you're managing complex allergic disorders, asthma is often going to be a part of the spectrum of allergies that they'll have. So that is why knowing effective management of asthma and what are the newer advances in asthma is also important for us. It might take a little while for Raj sir. Pradeep sir, can you introduce Vinay sir? Would it be possible? You're muted, sir. Pradeep sir. So I'll just introduce Dr. Pradip Prajapati is uh, one of the senior rheumatologists there. He practices in Baroda and he's the treasurer of Rheumatology Association of Gujarat. So over to you, sir.
Good morning, Dr. Vinay.
Morning.
Dr. Vinay, doing practice in California, Allergy and Asthma Associate of Southern California. Now, according to the time, we are going on, so we have to start it.
Yeah.
Over to you, Dr. Yeah.
Okay, sure. Well, thank you. Thank you, everyone. Thank you, Dr. Kunal, for organizing this and for inviting me. Hopefully, this will be important lecture for all of you. And so, as mentioned, if you can leave your cameras on, and just so that we can optimize our time together, and feel free to ask questions anytime during the presentation. So the title of this talk is Asthma: Comprehensive Approach to Diagnosis and Phenotype-Driven Management. And I'll explain what phenotype is. Just like in rheumatological diseases, asthma is not a singular monolithic disease. There are several types of asthma, several different types of presentations. And so the treatment is not the same uniformly. And this also is important when we talk about biologics. And we'll talk about 3 biologics that are currently available and utilized in India for the treatment of severe asthma. Okay, so these are the objectives. We'll talk about the current asthma burden and management challenges, and there are many, especially in India. I'm going to quickly talk about, what is uncontrolled versus what is severe asthma. We'll get into the asthma phenotypes, then we'll talk about the role of type 2 biomarkers. And so this is important, for you to understand and to know what they do, how they can influence treatment. And then we'll talk about 3 different biologics that is, now commonly utilized: omalizumab, mepolizumab, benralizumab. These are 3 biologics that are available and are commonly used in India. And then we'll talk about the clinical setting. Okay, so how do you put this together? And as mentioned, if you certainly, this is something that's managed by allergists and pulmonary physicians, but oftentimes, it's good as a rheumatologist to understand the immunology behind it. And in cases where there may be a lack of access to specialists, then certainly you guys can initiate therapy. So in terms of asthma burden, we know that asthma is prevalent. 30 plus million individuals in India have asthma. Now, while that only constitutes 13% of global asthma burden, unfortunately, in India, we have 42% of all asthma-related deaths occur every year in India. So that's about 200,000 deaths per year. Most of these deaths are preventable. Okay, so this is a problem. And in India, the mortality associated with asthma is about 3 times higher, and the disability in terms of adjusted life years compared to the rest of the world is about twice as much. We know that asthma and asthma exacerbations have a lot of consequences in terms of missed school, missed work, like, diminished productivity and very high expenditure. And this is important, especially in a country where, most of the burden of this cost is assumed by the patient. Whereas other countries, it's the insurance that takes care of it. In India, the cost is heavily on the patient. And so there are obviously management challenges. Now, when we talk about, where the problem arises, mostly it's in patients who have severe asthma. And so about 2.5% of children and about 10% of Indian adults have what we call severe asthma. And these are patients who tend to be symptomatic. So it's not that they're not taking medication, but in spite of taking medication, in spite of good adherence, good technique to high-dose ICS/LABA, so that's inhaled corticosteroid and long-acting beta agonist, these patients still have symptoms, which result in frequent visits to the doctor, ER visits, hospitalizations, and more importantly, is oral corticosteroid use. As rheumatologists, all of you know, I'm preaching to the choir, the dangers of corticosteroids. Even short-term corticosteroids can have ravaging effects. So we want to minimize OCS use. In India, the challenge is there's a paucity of specialists and there's limited access, especially in rural areas. The other challenge in India, which we don't encounter elsewhere, is in India, there's a high prevalence of ABPA, allergic pulmonary bronchial aspergillus, which is another challenge because these may not be pure asthmatics. They may also have ABPA, which also needs to be treated simultaneously. All right, so this is a question just to make sure that you're listening. So approximately how many Indians die from asthma each year? Okay, and if you can just chime in the answer, is it 1,000, 10,000, 100,000, 200,000? Maybe just one of you, if you can answer, unmute and just answer, that'd be. So how many patients die from asthma every year? Any of you? I need one volunteer.
200,000.
200,000, yeah. So that is the answer. So let's talk about, for those of you who may not be familiar, so what is uncontrolled asthma? So when we talk about uncontrolled asthma, we're talking about poor symptom control. And this goes back to the GINA guidelines. So I've sent you the GINA document. Every year, the GINA guidelines are updated. These are practical guidelines used internationally. And so there are 4 questions that you ask your patient. And this is a recall over the past 4 weeks. Have you had daytime symptoms more than twice a week? Yes or no? Any nighttime wakings due to asthma in the past, yes or no? Are you taking your reliever medication, that's the SABA, more than twice a week, yes or no? And any limitation of your physical activity due to asthma, yes or no? So uncontrolled would be if you check yes for 3 or 4. So that would be, uncontrolled asthma. 1 or 2 check marks would be partly controlled. To have well-controlled asthma, you have to answer no to all these questions. And about half of your patients, will not have good control, well control. And about a quarter will have uncontrolled asthma. So these are patients who don't have good asthma control. When you don't have good asthma control, this is when you increase the risk of exacerbations. So if you have 2 or more exacerbations past 12 months requiring OCS, oral corticosteroids, or if you have 1 severe exacerbation that requires hospitalization, then definitely your asthma is uncontrolled. When we're talking about severe asthma, this is a subset of these patients. So severe asthma is patients who have asthma. So you basically assumes that you have ruled out alternative diagnosis. Okay, so what are some examples? So you could, COPD, which is another common, it's very common. In fact, COPD is even more common than asthma. So these are, in the Indian scenario, a lot of times these patients actually never smoke. It's patients who are, especially women in their 40s, who are exposed to biomass fuel, from cooking. So especially in rural areas, people still use wood burning stoves. So these patients who've never smoked a day in their life often develop COPD. So that's the alternative diagnosis. Other presentations that can mimic asthma are any cardiac causes, vocal cord dysfunction. That's where you have stridor. That's when you have dysfunction of the vocal cords, which constrict. Anxiety often can be, can present as asthma-like symptoms, and then bronchiectasis. This is when you have, frequent respiratory infections with active productive sputum. So these are all things that you would have eliminated as in the differential diagnosis. Severe asthma also assumes that you have treated all the comorbidities. So we talked about ABPA. There's another condition called aspirin exacerbated respiratory disease, where patients have, when they take aspirin or NSAIDs, COX-1 NSAIDs, they develop asthma symptoms. These are patients who have chronic rhinosinusitis, nasal polyps as well. It assumes that you've treated the A or D. A lot of patients, about 40% of patients with severe asthma have chronic rhinosinusitis. About half have allergic rhinitis. Many have reflux. So all these comorbidities, have to be treated. A lot of them have depression, anxiety, sleep apnea is another comorbidity. So this assumes you've treated all these comorbidities. It also assumes that you have treated exacerbating factors. Either you've, removed exposure to these things like smoking. If the patient smokes, you made them quit smoking. You mitigated pollution, allergen exposure, biomass fuel exposure, obesity. You've optimized their medications, and you've checked the adherence. You've checked the inhaler technique. So once you have done all of these things, and yet patients still, their asthma is uncontrolled despite high-dose ICS/LABA, then truly you have what we call severe asthma. And these patients, again, they do exist. It's about 10% of asthmatics among adults and 2.5 among children. Just a note on ABPA, just for your awareness, ABPA is relatively common in India. It's about 5% prevalence among asthmatics, which is 2.5-fold times greater than the worldwide prevalence of ABPA. And this can occur in anyone with asthma. It doesn't have to be severe asthma. So there's a recent study published which found that prevalence of ABPA does not vary significantly based on severity. So you can be there whether it's mild, moderate, or severe asthma. And more recently, Dr. Ritesh Agarwal, he's the world authority on the ABPA, their group published or put out a guidelines, which recommend that in India, all asthmatics should be screened for ABPA, irrespective of asthma severity. So this is, again, important to recognize that, and this is a unique to India. The other countries don't have this, quite this challenge. The other thing I want to mention is that in India, especially, ARD is under-recognized and under-treated. So we know that about 7% in general of the adult population with asthma have aspirin-exacerbated respiratory disease. When we're talking about severe asthmatic, that incidence doubles, so about 14%. So I think you have to be looking for it. You have to ask patients what happens when you take aspirin, what happens when you take a COX-1 NSAID. And as rheumatologists, a lot of your patients are on NSAID, so you need to be aware that in certain percentage, this can actually exacerbate their asthma. And the treatment is actually quite simple. It involves aspirin desensitization. And it's important, not to say, well, just avoid the NSAID, just avoid the aspirin, because over time, these patients, even if they avoid NSAIDs, their asthma gets worse. So you actually have to treat the disease. It's an underlying disease where you produce, there's a dysregulation, there's upregulation of lipooctanoase pathway, which produces a lot of leukotrienes, and that's kind of the root of the disease. And the treatment is actually very simple, very cost-effective. It's aspirin desensitization. Okay, so it's a very simple procedure, but it must be done early in disease before patients develop airway remodeling. Okay, so this is something that you would send to your allergist or ENT. It's actually an outpatient procedure, but unfortunately, very few people do it in India. But again, this is very cost-effective. It just involves basically having the patient take high-dose aspirin every day. All right, so now, getting to the OCS issues, why this is important. Well, we know that oral steroids can be harmful. Even short-term courses can be harmful. In my area, there was a cohort study done by Kaiser where they looked at a large cohort of adult asthmatics over a 14-year period. They looked at those who received oral corticosteroids and those who did not receive oral corticosteroids. And what they found is that for each year of exposure to 4 or more courses of oral corticosteroids, these are short-term courses, it resulted in a 20% increase risk of having an adverse event in the current year. So what adverse events? We're talking about osteoporosis, osteopenia, hypertension, obesity, new onset diabetes, cataracts, GI bleeding, bone fractures, sepsis. These are all risk factors with OCS use. In fact, if you look at the current guidelines, it says that there's a risk of irreversible adverse events. That risk increases once you exceed a cumulative lifetime dose of just 1 gram of prednisone equivalent, which is not a lot of prednisone. So when we talk about, is there a safe dose? Is there a safe amount of oral corticosteroids? Well, it's surprising the threshold is very low. So any person who has exceeded 1 gram of prednisone equivalent in a lifetime, their risk of adverse events goes up. So this is something that we really need to be aware of. And it's also important to know that just because you put someone on OCS in severe asthma, just because person is on triple therapy doesn't mean that it necessarily reduces the steroid burden. And what I mean by this is an observational study. I was part of this study where we looked at nearly 5,000 patients, both children, adolescents, and adults. These patients all had what we call severe asthma. And what you see here is that irregardless of whether the patient's taking 1 controller, 2 controllers, or 3 controllers, they continue to have asthma symptoms. They continue to require oral corticosteroids. So these are patients on triple therapy. So you can see that nearly half of them still required a burst of oral steroid in the last 3 months. So there is an unmet need in that regard. And so that comes into that's where biologics can play a role. So what are, biologics and why use biologics? Well, they selectively target type 2 inflammatory pathways. And as rheumatologists, and you guys are very familiar with biologics. You use biologics in many rheumatologic conditions, I'm sure. In asthma, these are highly effective by they improve asthma control, they reduce the number of exacerbations, and they're corticosparing. So they target narrowly the T2 inflammatory pathways. It allows you to reduce your oral steroid use, and this is especially important in growing children. Oftentimes these patients will have significant HPA axis suppression if you give oral steroids. It will stunt their growth. It'll cause diabetes and all kinds of devastating consequences. They are safe, and we'll talk about safety. Of course, the challenge is cost and access are some of the challenges. Yeah, now this is a table that all of you should be familiar with. This is part of GINA, and every year, as I mentioned, GINA updates their guidelines. And the point I want to make here is that once you get into here, step 5, which is severe asthma, patients should have their asthma phenotype assessed. Okay, so it says here, refer for assessment of phenotype. And then if patients qualify for biologic, consider either anti-IgE, which is omalizumab, anti-IL-5, which is mepolzumab, anti-IL-5 receptor alpha, which is beneluzumab. Okay, so we'll talk about these 3 biologics. Anti-IL-4 receptor alpha, that's dupilumab. That is not yet approved in India for asthma. It is approved for atopic dermatitis, but it is costly, so I won't talk about that. And then there's a newer biologic, which is anti-TSLP. This is not approved nor available in India, so we won't talk about it. But these 3, I think, anti-Ig and anti-IL-5, you should be aware of. And these biologics can be used both in adults, 12 and older, and also in children. Okay. Oral steroids should be given only as a last resort, okay, for the reasons I mentioned. So what does this mean, refer for phenotype assessment? Well, it turns out that asthma, well, first of all, what is phenotype? So it's a set of observable characteristics of an individual resulting from the interaction of its genotype with the environment. So this is a gene-environment interaction. So asthma will present in a certain way. And that's what that is a phenotype. And so there are actually multiple asthma phenotypes. And the important concept here is to distinguish between T2 high and non-T2 high asthma. Okay, so T2 high asthma is driven by both allergic or eosinophil inflammation. Why we call it T2? Because mediated by Th2 cells and T2 inflammatory cells. So those are eosinophils, basophils, mast cells. If you look at cytokines involve IL-4, IL-5, IL-13, these are all T2 cytokines. And it is in these phenotypes, these type 2 phenotypes, where biologics can play an important role. Not only do biologics play an important role, but also even inhaled corticosteroids and even oral corticosteroids, they tend to respond better in this type of asthma versus non-T2 asthma, which is more neutrophilic or polygranulocytic, meaning if you were to do a bronchoscopy and look at the BAL fluid, you don't see a lot of cells. So these patients, unfortunately, don't respond as well to inhaled steroids, which is really the cornerstone of asthma treatment, and they don't respond well to biologics. So here's an example of phenotypes. Okay, and if you can see these severities on the y-axis. Down here is different ages, childhood onset, adult onset, and what you see here is that so as a child, most of the asthma is actually allergic asthma. It's 89% of children with asthma, they have allergic sensitizations, meaning if you did a skin test or if you did in vitro blood test, you would see a lot of sensitizations. In India, the most common sensitizer is dust mite, followed by cockroach and mold sensitivity. And so this drives their disease. In adults, so adult onset is more late onset eosinophilic. You may have AERD. And the point here is that all of these different phenotypes, are associated with elevated FeNO levels, elevated blood eosinophil levels, and these are the ones that respond to inhaled steroids. They respond to biologics. And this represents about 2/3 of all asthmatics. In this bucket here, these are what we call T2 low phenotypes. This is more, this is where you have normal FeNO levels, normal eosinophil levels. We see this with, obesity. So patients who are obese, generally may not respond well to conventional therapies. We see this with smoking. Smoking actually causes neutrophilic inflammation, which doesn't respond as well to inhaled corticosteroids. And we see this in patients who have smooth muscle dysfunction. They have a lot of smooth muscle, so their smooth muscle load is very high, but they don't have really inflammatory. They don't have too many inflammatory cells, and so there's really no target. The steroids really don't work as well in this population. So that's important to know, that asthma is heterogeneous, just like most of your rheumatological diseases are heterogeneous. You can't assume that one therapy fits all sizes. So again, T2 high asthma, which is these patients right here, they generally have more severe asthma. They associate with airway and systemic eosinophilia. They respond well to corticosteroids and they respond well to biologics. Whereas this patient population here, they generally have less severe asthma. Fortunately, you see an absence of airway and systemic eosinophilia. They don't respond well to corticosteroids, and they do not respond well to biologics. Now, one of the things that, so what are the biomarkers that we use? Well, this turns out, when you look at different epidemiologic studies, this is one from the UK, which was done over a 2-year period, over 130,000. These were adults with asthma. And what they found is the blood eosinophil level can be a good predictor of risk of asthma exacerbations. And so again, this is a large, in a population. At the population level, the higher the blood eosinophil count, the greater the risk of having an asthma exacerbation over the next 12 months. And so what we can see here is the cutoff is really 300. So 300 cells per microliter. Once you exceed that, the relative risk of having asthma exacerbation goes up. Especially if you're at this level, over 1,000 cells per microliters, then there's really a 2.5-fold risk of developing an asthma exacerbation. So just looking at a CBC, looking at the eosinophil count is important. And unfortunately, not many people do that. I would encourage you to, in all of your asthmatics, just look at their CBC values, look at their eosinophil count. That is an important biomarker. The other important biomarker is exhaled nitric oxide, which basically measures in tidal breath, exhaled breath. It measures the level, and this is measured in parts per billion. And this is a surrogate marker of eosinophilic inflammation. And, so that is an independent marker associated with not only the risk of asthma, but also risk of asthma attacks. So both blood eosinophil levels and exhaled nitric oxide are independent biomarkers. When the levels are high, you are in an asthmatic, you are more likely of having an asthma exacerbation. And so these are two important biomarkers. And this data here was from the US cohort, looking at over 12,000 patients, and these were the observations. So important to know. So just getting back to FeNO, for what is FeNO? It's actually a marker of T2 airway inflammation. So exhaled nitric oxide Okay, is an endogenous regulatory molecule. And as you know, nitric oxide is produced everywhere, but in the lung, nitric oxide actually acts as a vasodilator, as a bronchodilator, and as a neurotransmitter. And it's an important mediator of the inflammatory response. And it's synthesized and regulated by this family of enzymes called nitric oxide synthetase, which itself goes up when you have oxidative stress. And this enzyme, there's a constitutive level, so you have a baseline level of NO that's being produced, but it can also be induced. And you see the maximum amount in the bronchial wall epithelial cells. So during type 2 inflammation, these levels go up and correspond under the regulation of IL-4 and IL-13. These levels go up and often correlates with eosinophilic inflammation. And so when you put these two biomarkers together at a population level, we know when you, in the presence of high blood eosinophil level, meaning greater than 300 cells per microliters, and a high FeNO level, meaning greater than 50 parts per billion, these are the patients over here who have the highest risk of having acute asthma exacerbation. Okay, so again, high blood eosinophil level, greater than 300, and a FeNO level greater than 50. These are the patients who are most likely to have an asthma exacerbation. So these are important biomarkers to understand. Other factors associated with increased risk of asthma exacerbations is having a history of exacerbations. So the more exacerbations you've had in the past 12 months, the more likely you're to have exacerbation in the future. So, cutoffs are either, 2 or 3, depending on which country, we're talking about. So definitely, if a patient has had 3 or more exacerbations in the past 12 months, these patients would likely benefit from a biologic, or 1 severe exacerbation requiring ER visit or hospitalization, or anyone who needs OCS, or patient with nasal polyps. So this is another important aspect. A lot of times patients with asthma, they'll see either a pulmonary physician or an allergist. Typically in India, we don't do rhinoscopies. The typical pulmonologist, typical allergist will not look at their upper airway, which is important because a lot of these patients with severe asthma also have nasal polyps. And so it's important, and nasal polyp itself is an important risk factor for asthma exacerbations. So it's important to treat both the upper and the lower airway. Okay, so this is another trivia question. Okay, so I just need 1 volunteer. So T2 high asthma is characterized by which of the following? Elevated FeNO, unresponsiveness to inhaled corticosteroids, elevated neutrophil count, or D, associated with smoking. Okay, so T2 high asthma is characterized by which of the following?
Elevated FeNO.
Elevated FeNO, right. Okay, so that should be crystal clear. Any questions so far before I go on? Any questions? Dr. Kunal, have they had a lecture on FeNO or?
No, they have a practical demonstration of FeNO in the workshops that they have.
Okay. Yeah, and again, the challenge is that even among specialists, FeNO is not always utilized. So it is maybe as a rheumatologist, maybe you should be at the forefront and check these things because it's important.
Just a
Right.
rheumatological question. Would any inflammation in the lung have an elevated FeNO? So let's say a neutrophilic inflammation, would that cause?
No, so neutrophilic inflammation will not have an elevated FeNO. Obesity will not have, so obesity is associated with IL-6 elevations. So IL-6, as we know, unfortunately, we don't have a good test for IL-6. CRP is also elevated, by the way. CRP can be elevated in neutrophilic asthma.
Sir, one question.
Yeah.
Sir, is there any correlation with level of pheno and eosinophil? Is it possible to
Yes.
have high eosinophil and low pheno and high pheno and low eosinophil? So
Yeah,
what?
well, anything is possible, but usually they track together.
Okay.
Okay, so in the past, so when I say in the past, I'm talking about 20 years ago, we used to check induced sputum. We used to count, anyone who came in for an asthma exacerbation, and I did this as a resident. When I was a resident, this was 25 years ago, we would collect sputum and the resident or the medical student would stay in the slide with H&E and actually physically count the number of eosinophils. And of course, nowadays, no one does this, but pheno itself, and no one, nor do people routinely do bronchoscopies. But pheno definitely has good correlation. The higher the pheno, in general, the higher the eosinophil level. Okay. All right, now, so we'll talk about, so biomarkers. So again, just like in rheumatological diseases, you have biomarkers, there's things you check. You check SED rate, CRP, you check ANA, you check rheumatoid factor, anti-CCP, all these things, ANCA as well. Fortunately, in our world, there's only two biomarkers, blood eosinophil levels and pheno. And both of these can actually help you in establishing a diagnosis of asthma, in phenotyping asthma, in risk, prognostication, and in selecting appropriate therapies. Okay, as I mentioned, inhaled steroids don't work as well when you have a low pheno, low eosinophil count. And actually, so this is something that's it's a relatively new concept, and it is actually in the GINA guidelines right now. So, for example, we know that many times, spirometry is unavailable, even peak flow value may be unavailable, or, there may be challenges where patients not able to do, especially children, very often they're not able to do a proper spirometry, or the testing may be normal. But they still have symptoms suggestive of asthma. So in that situation, the diagnosis of T2 high asthma is supported if you have a high pheno level. So if it's greater than 50 in adults or adolescents, or if it's greater than 35 in children, that is supportive that maybe this person has asthma, T2 high asthma. Also, if their baseline blood eosinophil count is above the national or regional reference, and this is important. We know that in India, because of the high parasitic load, the average person may have higher eosinophil levels. So I think it's important to have, national, regional cutoffs, references, so that, but again, having these two biomarkers being elevated supports the diagnosis. Of course, it's just supportive. It's not diagnostic of anything. So you have to, many non-asthmatic conditions can elevate pheno and blood eosinophil levels, even things like allergic rhinitis, chronic sinusitis, ABPA, eosinophilic pneumonia, things like that, atopic dermatitis. And of course, in India, parasitic infections are quite common and have to be considered. This is straight from GINA. Okay, so the other thing is the timing. So there's certain things that you have to be aware of. The factors that can affect blood eosinophil levels, pheno levels. Blood eosinophil levels, generally are higher in males. They're generally higher early in the morning. This has to do with a cortisol level. Okay, so generally higher levels in the morning versus the afternoon. Obviously, parasitic infections can increase the eosinophil counts. Other allergic diseases and things like EGPA, eosinophilic bronchitis, ABPA can also elevate the eosinophil levels. Things that can lower the eosinophil levels. So if you have non-T2 high asthma, and also if you are taking steroids, sometimes even inhaled steroids can suppress to a certain degree the eosinophil count. This here is a very common problem. And I'm sure in rheumatology you see this all the time. Patients are always put on steroids, so it's hard to check biomarkers when you're on oral steroids. So this is something, of course, you have to be aware of. And in terms of pheno generally, again, is higher in males compared to females, but it's higher in the afternoon versus the morning. So it's the inverse. Blood neutrophil levels are higher in morning versus pheno is higher in the afternoon. Also elevating other allergic conditions. Smoking actually lowers the pheno level. And again, pheno can also be lowered if you're taking inhaled steroids. Well, of course, oral steroids, but even inhaled steroids can lower the pheno level, which actually is, in a way, you can actually track in some if you have patients where you know their baseline pheno level and you want to check adherence to inhaled corticosteroids, you can actually track it through pheno. So you know if their patients are really taking their medication or not. So that's another approach. Of course, that implies that patients have an at-home pheno machine they can track values. We're not there yet. Okay, we talked about this over here, so they can help in diagnosis of asthma based on these cutoffs. In terms of prognostic value, if patients on inhaled steroids who have a history of exacerbations, if you have a high pheno or high blood neutrophil levels, well, that is certainly associated with an increased risk of exacerbations. I mentioned, blood neutrophil levels greater than 300 increases the risk of exacerbations. Same thing with pheno. High pheno level will also increase your risk of exacerbations. And this has a role, in terms when we talk about biologics. I think here we go. It's in the next slide. Higher the blood neutrophil level, the higher the response to any of the biologics, asthma biologics. And then for pheno, the higher the pheno level, the more likely you are to respond to omalizumab, dupilumab, and tezepelumab. Okay. When we are checking levels, sometimes you need to repeat, and the GINA guidelines recommends checking up to 3 times. So initially, if the blood neutrophil level, the pheno level is low, keep checking up to 3 times, because again, these levels can fluctuate depending on the time of the day when they were captured, and also depending on whether patients were on systemic steroids or not, which is again a very common confounding issue in these patients. And in terms of predicting response, these biomarkers are important. So particularly with your response to treatment to inhaled steroids, the higher the blood neutrophil level, the higher the pheno level, the more likely you are to respond to inhaled corticosteroid. And in terms of biologics, a high pheno predicts a better asthma response to dupilumab, omalizumab, and tezepelumab compared to a low pheno level. Whereas with these two, mepolzumab and benralizumab, these anti-IL-5 therapies are independent of pheno levels. Okay, and I'll talk more about that in a second here. But again, this is important in the sense that these biomarkers can predict to which biologic your patient is going to respond to. And again, as I mentioned, this is a challenge in India because you have a high prevalence of parasitic infections, which can falsely elevate the pheno levels. And parasitic infections can falsely elevate blood neutrophil levels, and then you have a lack of phenotestin availability. And so that's a challenge. And also the challenge that patients are often put on steroids, even long-term steroids. So when you have someone who's taking long-term prednisone, it's hard to, these levels are going to be suppressed. So that is a challenge. All right, so we'll switch gears now. We'll talk about the biological proof for the treatment of severe asthma. And, basically in a nutshell, this is looking at some of the inflammatory mediators that drive asthma. We'll talk about omalizumab, which is IgE blocker. And then we'll talk about the anti-IL-5s. IL-5 is a cytokine that drives eosinophil inflammation. So we'll talk about mepolizumab and we'll talk about benralizumab. And again, these are currently available and approved in children and in adults. So anti-IgE, as you know, is omalizumab is anti-IgE therapy, has been around for over 2 decades. And it is a humanized monoclonal IgG antibody against IgE. Okay, when I say humanized monoclonal, I mean it's not fully humanized. There's about 5% of the molecule that's murine based, and because it's murine based, there is a slight increased risk of anaphylaxis. The risk of anaphylaxis with omalizumab is about 0.2%. And what omalizumab does, it binds circulating serum IgE. It forms inner complexes. And so these inner complexes then therefore are not able to bind IgE receptors on mast cells and basophils. And so how this works, so you have, as you know, B cells produce and release IgE. Omalizumab binds this free IgE in the serum. And so by doing so, it actually decreases the expression of high affinity, what we call Fc epsilon R1. These are high affinity receptors on mast cells and basophils. How it does this is, this is an equilibrium. So your serum level of free IgE modulates the density of Fc epsilon R1 receptors on mast cells and basophils. So by decreasing free IgE in the serum, you actually reduce the number of IgE receptors on your tissue-bound mast cells. And so by doing so, it reduces the threshold, it increases the threshold of mast cell degranulation. So your mast cells are less likely to degranulate because now they have less IgE receptors bound on their surface. And so this decreases allergic inflammation. You have less mast cell activations and therefore less allergic inflammation. It also helps prevent and reduce exacerbations. So the bottom line here is omalizumab works by decreasing allergic inflammation, decreasing mast cell and basophil activation. And so it has been around for over 2 decades. It is approved down to age 6 in patients with moderate or severe allergic asthma. So by moderate, we mean 1 exacerbation past 12 months. Severe means 2 or more exacerbations in the past 12 months requiring systemic steroids. Because it is acting on mast cells, it requires, and mast cells are triggered by VI IgE-mediated pathways. It does require some sort of IgE-mediated sensitivity to a perennial allergen, meaning you have to have a positive blood test or a positive skin test to either dust mite, animal dander, cockroach, or mold. These are all perennial allergens. It also assumes that you have a certain IgE level. Okay, if the level is too low, then there's no point giving omalizumab. The level already of IgE is low because omalizumab is binding IgE in the blood. So you have to have a certain level, minimum of 30. On the opposite end, if your serum IgE level is too high, then that would imply you need a lot more omalizumab to achieve the same effect. And so there's a dosing range between 30 and 1300, or in India, it's 30 to 1500, I believe, beyond which you would not use omalizumab. Because this is in part a murine molecule, anaphylaxis can occur, and the rate is about 0.2%. Most of these reactions occur during the first 3 doses. And so the recommendation is to give at least the first 3 doses in the office, and then if the patient is doing well, hasn't experienced any adverse events, they can self-administer at home. But we do give all patients on omalizumab must carry epinephrine in the event of anaphylaxis. The dosing is based on body weight of the patient and serum IgE level. And that is the reason for getting a serum IgE level. So the dose is 0.016 milligrams per kilo of body weight per international units of IgE. And this is dosed, so per month. And so this translates to between 75 to 375 milligrams subcutaneous every 2 to 4 weeks. This here is the dosing guidelines, and this is very important. I think a lot of times we don't pay attention to this, but it is important. In a patient 12 years and older, generally the IgE level has to be between 30 and 700. If it's above 700, if it exceeds 700, the recommendation is do not dose, because then you'll exceed 375 milligrams every 2 weeks. And that's the higher the dose of omalizumab, the more costly it becomes. And so at a certain level, it's not practical to give omalizumab. In children aged 6 to 12, we do allow a greater IgE threshold. But again, if the baseline IgE is over 1300, the recommendation is do not dose. Okay, and again, the reason for this is it becomes a practical issue. It's difficult and also very expensive once you have to give more than 375 milligrams every 2 weeks. It's not practical. And so this is, I think, an area where a lot of times, we don't understand this. Patients are still given omalizumab, but the response that these patients will not respond as well if you exceed the dosing guidelines. As I mentioned, first 3 doses have to be done in the office. Typically, I will have monitor them for about an hour in the office. Doesn't require hospitalization, doesn't require ICU monitoring. Just in their office is sufficient. And then if we've had 3 doses without any adverse events, then they can dose at home. And we do have good data. As I mentioned, omalizumab is the first biologic we use. It came out in 2003, so over 20 years of experience. This was a Cochrane review looking at 25 randomized controlled trials in patients with moderate to severe asthma who were on inhaled corticosteroids, to which omalizumab was added. And you can see the reduction in asthma exacerbations, from 26% to 16% over a period of 16 to 60 weeks. It cut down on asthma-related hospitalizations from 3% to 0.5%. However, it doesn't have that good benefit on FEV1. So in other words, it's not going to improve your lung function by that much. That's an important concept to understand. It does allow you to decrease your dose of inhaled corticosteroid, but it did not, in those patients who were receiving oral steroids, we do not see reduction. So it did not allow patients on OCS to come off of OCS. That's an important limitation of omalizumab. And in terms of severe asthma, this is another randomized controlled trial. These were 850 patients who were not only ICS, but were on high-dose ICS plus LABA. And they were given either omalizumab or placebo for 12 months as an add-on. And here the annualized rate of reduction of asthma exacerbation was about 25%. So, by giving omalizumab, roughly you're reducing by 25% the number of asthma exacerbations. Now, what are the side effects? So commonly what we see is injection site reactions occurs in about 12%. So at the site of the injection, again, this is subcutaneous, you can develop erythema, pain, swelling. That may be related to the excipient in omalizumab. We fully don't know why, but it does occur. Anaphylaxis, as I mentioned, can be immediate or delayed, occurs in 0.2%. And then, of course, for the rheumatologist, as you know, with biologics, sometimes you can develop drug-associated antibodies. In this case, we don't see that many, fortunately, less than 1%. What predicts good response to omalizumab is nothing to do with IgE. Okay, IgE levels are not predictive of response. The number one predictor of response is these two biomarkers, high EO, high FeNO. So in the context of high EO, high FeNO, you are more likely to respond to omalizumab. Also, if you have allergen-driven symptoms, okay, that makes sense because this stabilizes mast cells. So the more allergies you have, the more likely to respond to omalizumab. And also children can respond, or I should say childhood onset asthma responds better to omalizumab compared to adult onset asthma. Now with omalizumab, you also have other indications. So you can use omalizumab also in patients. It's been shown to be effective in patients with chronic rhinosinusitis with nasal polyps, in patients with chronic spontaneous urticaria, in patients with food allergies. So these are some other indications for omalizumab. We also use off-label omalizumab in patients with ABPA. Okay, so when you're selecting biologics, it's important to know what other comorbidities patients have. Okay, so let me ask a trivia question here. What is the mechanism of action of omalizumab? A, increases expression of high-affinity mast cell receptors. B, binds to mast cells, preventing degranulation. C, binds to free serum IgE. D, prevents IgE class switching. If you can unmute and give the answer. I'm sorry, I didn't catch that.
Answer is C.
C, yes, binds free serum IgE. Yes, very good. All right, I'm going to accelerate here. I know time is short, so we'll talk quickly about anti-IL-5 and anti-IL-5 receptor. Okay, so the first one is mepulizumab. So mepulizumab is a monoclonal IgG1 antibody, illustrated here, that binds circulating IL-5, interleukin-5. And so by binding here, it prevents IL-5 from attaching itself to the IL-5 alpha receptors on the eosinophil. As you are well aware, IL-5 is a key cytokine responsible for growth, recruitment, survival of eosinophils. And so when you give mepulizumab within 48 hours, the blood eosinophil levels are suppressed by about 80%. Okay? And clinically, it is approved for severe eosinophilic asthma. So, technically, if you have 150 or greater eosinophil count, probably in the Indian scenario, I would use at least 300 as cutoff level. Here's the dosing. So this is not based on body weight. It's fixed. So patient 6 to 11, it's 40 milligrams sub-Q every 4 weeks. For adolescents and adults 12 years and older, it's 100 milligrams every 4 weeks. It can be given at home. It can be given in the office. Does not have an anaphylaxis warning, but does have certain side effects. So headaches being the most common. We don't fully understand why these patients get headaches, but they do. Injection site reactions, neutralizing drug antibody, fortunately very few, less than 1%, but it does have a slight increased risk of herpes zoster. And so the recommendation is to administer the herpes zoster vaccine prior to initiating mepulizumab. For mepulizumab, there are other indications for which it is approved. So namely COPD with eosinophil phenotype, chronic rhinosinusitis with nasal polyps, EGPA, hypereosinophilic syndrome. Okay, so when you have in the presence of high eosinophil count greater than 1,500 for more than 6 months without identifying cause, this can be used. And then ABPA, off-label, can be used for the treatment. I'm going to okay, so yeah, another trivia question. Which of the following statements is false? Mepulizumab is an IgG humanized monoclonal antibody that binds to IL-5. Mepulizumab is indicated for the treatment of eosinophilic asthma in patients 6 years years of age or greater. Dosing of mepulizumab in adults is based on patient weight, or D, mepulizumab is indicated for treatment of chronic runny sites within polyps. Okay, very quickly,
C.
which is false?
C.
Yes, it is not based on it's a fixed dose in adults, 100 milligrams every 4 weeks. All right, so we'll contrast that with benralizumab, which is the other anti-IL-5. So benralizumab is another IgG antibody, but this time it actually binds directly to their IL-5 receptor on eosinophils. So by doing so, it obviously blocks IL-5 binding, but more importantly, it induces what we call NK. So NK is natural killer cell, antibody-dependent cell-mediated cytotoxicity. So the natural killer cells become attracted to the Fc portion of the benralizumab molecule, and by doing so, natural killer cells then will induce apoptosis. So it will completely destroy the eosinophil, such that within 24 hours of receiving benralizumab, the blood eosinophil level drops, it goes to 0, and the sputum eosinophil, goes, maybe to 10% of baseline. So this happens very quickly. So the main mechanism here is cytotoxicity, eosinophilic apoptosis. And again, this is approved in adults and children down to age 6. For adults, the dosing schedule is what is unique about benralizumab is it's every 4 weeks for first 3 doses, and then can go to every 8 weeks. And the dosing is based on weight. So for those 35 kilos or more, it's 30 milligrams. For those weighing less than 35 kilos, it's 10 milligrams. And again, this is administered at home or in the office. Here, the potential side effect is we do see neutralizing drug antibodies. So in other words, potentially this can, and perhaps this has to do with the dosing. We know that with biologics, the longer you go in between doses, the more likely of developing drug-associated antibodies. So because the dosing is every 8 weeks, we do see a higher rate of drug antibodies. We also see headaches, although not as commonly as mepulizumab, fever, and hypersensitivity reactions. In addition to severe eosinophilic asthma, benralizumab can also be used for AGPA, and it is used off-label or can be used off-label for ABPA. Okay. So very quickly, which statement best differentiates benralizumab from mepulizumab? Benralizumab directly prevents IL-5 from binding to the IL-5 receptor. Benralizumab binds IL-5 receptor alpha and activates complement-mediated lysis. Benralizumab causes eosinophil depletion through Fc-mediated antibody-dependent cell-mediated cytotoxicity, or benralizumab reduces synthesis of IL-5 in Th2 cells.
C.
Which one?
C.
C. Good. All right. In terms of efficacy, so how does this compare to omalizumab? Well, these are better in terms of efficacy. So you have about 50% reduction in asthma exacerbations, especially in patients who have high eosinophil levels, meaning greater than 300. You see a better improvement in lung function. Okay, and you also, unlike omalizumab, studies have shown reduction in OCS use in patients who are OCS dependent. Predictors of good response: high blood eosinophil levels, frequency of exacerbation in the preceding year. The higher number of asthma exacerbations in the preceding year, the more likely you are to respond to either mepulizumab or benralizumab. Adult onset asthma versus childhood onset asthma, nasal polyps, and here, unlike omalizumab, FeNO level does not predict response. Okay. That being said, as I mentioned before, usually eosinophils and FeNO levels do track, so they're generally correlated. This is a table to quickly summarize the three, so omalizumab, which is anti-IgE, the biomarker associated with reduction in exacerbation rate. These are the outcomes. Okay, so and what it targets. And then we have your mepolizumab and benralizumab. Again, here the biomarkers are high blood eosinophil levels, but it is not associated with, FeNO is not a biomarker here for neither mepolizumab or benralizumab. We do see, however, greater reduction in asthma exacerbations, about 50% versus 25%, and you see a more robust improvement in FEV1 compared to omalizumab. Okay, so for the sake of time, I won't spend too much time here, but again, important to look at these differences. All right, so very quickly, as a clinician, how do you put it together in your patients? Well, I think for any asthma, especially if they're not doing well, first of all, you want to make sure that you do all the proper assessments. First thing is first, you want to confirm that the patient actually does have asthma, true asthma, and it's not a mimicker. You want to make sure their treatment is appropriate and adhering to GINA guidelines. You want to review inhaler technique. Unlike pills, which are easy to take, you just swallow it. This actually requires, there are different inhalers. There's dry powders, soft mist, MDI. So you really need to make sure patients are taking their inhalers correctly. You want to treat exacerbating factors as well as comorbidities, if there are comorbidities. Okay, these all have to be, especially nasal polyps, you have to treat them aggressively, not just treat their asthma. Second is you want to make sure you want to assess their level of asthma control. This is based on the GINA guidelines, those 4 questions that I alluded to. You want to identify risk factor for exacerbations, and you want to look at their OCS use. And then in terms of laboratory testing, obviously spirometry for the pulmonologist, to get a sense of their lung function, blood eosinophil levels, very easy to assess and obtain, FeNO if you can. And then for the allergist, of course, allergy testing. And in terms of IgE, that is for omalizumab dosing purposes. So once you have this information, the next question is, okay, well, does my patient have T2I asthma? Because these biologics only work in T2I asthma. So meaning you have high blood eosinophil levels, high FeNO levels, sputum eosinophilia, patient or OCS, allergen-driven asthma, nasal polyps. So in the presence of these, you probably do have T2I asthma. You may want to consider empiric treatment with antiparasitic. In fact, even before you check these things, again, given the scenario, if you suspect the patient may have parasitic infection, go ahead and treat it with antiparasitic before you get these levels to make sure that they're not falsely elevated. In the Indian scenario, you want to screen these patients for ABPA, screen for AERD. And, as a rheumatologist, I think it's important. If you have a very high eosinophil count, greater than 1,500, then you want to, don't just assume this is asthma related. You may want to check for other diseases. And certainly there are rheumatologic conditions like EGPA, which is a vasculitis that can cause high eosinophil count. So you do have to do your proper workup. Then, and this is extremely important, before you talk about biologics, first of all, you have to make sure that it's affordable, available. Costs are certainly an issue you need to discuss with patients. And before you consider starting therapy, again, screen and treat for any possible parasitic infections. You want to optimize your baseline standard of care therapy. In the presence of ARD, consider aspirin desensitization. In the presence of ABPA, you would treat appropriately with steroids, ibuprofen. If you have a patient with nasal polyps, send them to ENT, your ENT colleague. Get rid of the polyps that may actually improve their asthma without having to even utilize a biologic. And then the next is, if you say, yes, my patient does have T2I asthma, I've managed all their comorbidities as best as I can, and that they would benefit from a biologic, then the question is which one to use. And this is based upon costs, it's based upon comorbidities. Okay, so for example, with Zola, with omalizumab, omalizumab, it can also be used in patients with nasal polyps. It can also be used to treat chronic sinusitis, to treat chronic spontaneous urticaria. So you have to look at not only asthma, but what other comorbidities, what other indications the biologic has. In the case of omalizumab, you have to have a positive skin test to one of the perennial allergens. The IgE has to be within dosing range. And these are the predictors of good response. So high blood infil levels, high FeNO. With the anti-IL-5s, what predicts response is high blood infil levels, high level of exacerbations in the preceding 12 months, adult onset of asthma, nasal polyps. And again, because it's acting on eosinophils levels, you really have to have high eosinophil level at baseline. Once you've initiated therapy, then within 3 months, at least, or every 3 months, you really need to be monitoring for response. Are they getting better? So in terms of symptom control, asthma exacerbations, lung function, if you're treating other type 2 comorbidities, are those type 2 comorbidities getting better? Are the patients having any side effects? Is quality of life improving? So those are important things to do, to monitor every 3 months at least. Assuming that they do get better, then the first thing you want to do is throw an oral steroid, try to reduce oral CS use. That is the most important thing to do. And secondly, is gradually reduce the dose of inhaled corticosteroid. Okay, but this has to be done very carefully, very gradually. And then last, because of cost considerations, do I need ongoing biologic therapy? None of these things, unfortunately, are curative, but we also have to be practical in the sense that these things are costly. And so you have to be mindful of that. If, on the other hand, you do not see a good response, then, stop the biologic, especially if you don't see response after 3 to 4 months, stop the biologic. Then you really have to go back to the drawing board. Is this truly asthma? Is this truly T2 high asthma? Have I missed something, right? So this is when you go back to the drawing board. You check for other mimickers of asthma, get a CT scan. If you haven't, in the context of, T2 low asthma. So if you don't have T2 high asthma, what are some of the therapies you can use? Well, think about, minimizing exposures. So if the patient is smoking, you tell them to quit smoking. You try to reduce exposure to pollution, irritants, like biomass fuels, diesel particles, weight loss in your obese patients. LAMA is things like tiotropium. These work independently of either T2 high or T2 low asthma. Also, low dose azithromycin has been helpful in these patients because of its anti-inflammatory properties. And again, review, check technique, check adherence. These are all important aspects that have to be done at every visit. All right, so last question. So 22-year-old woman with poorly controlled asthma despite high-dose ICS LABA. She's had 2 asthma exacerbations in the preceding year. CBC reveals a blood eosinophil count of 400, serum Ig is 600, skin tests are negative. Okay, so which of the following add-on therapies would you choose next? So hopefully this question summarizes the talk. Let's see from the audience. I want audience participation. So first of all, first question, is this T2 high asthma? Yes or no?
Yes.
Yes. And when you say that, because of what?
Eosinophil count still elevated IgE.
Okay. So more importantly than IgE, it's the blood eosinophil count is high. Okay, so the blood eosinophil count is high, the IG is high. We don't have a pheno here, but okay, so T2I asthma, okay. So would this patient benefit from a biologic in the case of T2I asthma?
Yes.
Yes, okay. So which of the following add-on therapies would you choose next? Does this patient qualify for omalizumab? With omalizumab, you need to have positive perennial allergens. Here, the skin tests are negative, so it does not qualify for omalizumab.
Yes.
Does this patient qualify for mepolizumab?
Right.
So yes, so this is eosinophilic asthma, yes. Mepolizumab indicated for severe eosinophilic asthma, meaning 2 exacerbations. So she's had 2 exacerbations. So the answer is yes, does qualify for mepolizumab. Similarly, she also qualifies for benralizumab. Okay, so eosinophil count is greater than 300. We have 2 or more exacerbations. So, but if you look at the question, before you start, actually, this is a trick question. So before you start a biologic, what is something that we haven't done? And that's Q12.
Yeah.
Okay, this goes back to the GINA guidelines. So, if you look at way back here, before you start a biologic in an adult, you first, to your high dose ICS LABA, you add on LAMA, then you consider biologic. So it becomes, it's a cost efficiency question. So before you start an expensive drug, you want to optimize your standard of care drug. So anyway, bottom line, take-home messages. So diagnosis and management of asthma, riddled with many practical challenges, particularly in patients with severe asthma. Keep in mind that asthma is a heterogeneous disease. There are different phenotypes. There's T2 high phenotypes, T2 low phenotypes. Type 2 biomarkers can play a supportive role in the diagnosis, in the phenotyping, prognosis, and selection of therapy. So that's your CBC with diff, showing eosinophils, and that's your pheno. Biologics can play a beneficial role in the treatment of severe asthma, particularly in patients with other type 2 comorbidities. But the decision to initiate therapy and the selection of the biologic must be made only after careful clinical correlation, especially in a country where these therapies are very expensive. Oftentimes, patients have to assume the costs. So I think it's important, and it's important as a rheumatologist, maybe, when you see patients, closely collaborate with your allergist specialist, closely collaborate with your pulmonologist. And as, of course, as a rheumatologist, you also have to be aware of how these biologics work, what are some potential side effects. Okay, so I'm going to pause there. I know I went over time, but if there are any questions,
Thank you so much,
I'd
sir.
be happy to take.
Yeah, we did enjoy it very well. We have the other chair who has joined us. So if we can welcome Dr. Raj Bhagat. He's the senior most allergist that is there in our part of the country, and we can ask a few questions. I'm sorry we can't probably cover the entire set of questions that's been asked. We have had a lot of questions that have been asked. We'll probably message you all of them, so you can either write them, or if we get the time in the next session, we have food allergy, probably we can answer them.
Okay, go ahead.
I think, sir, from 1 or 2 questions can be picked up from all. But I really congratulate Dr. Mehta. You had gone very nicely, and the approach was very fine, going from the symptom severity, phenotyping, your eosinophil relation, and biologics. It was excellent. I thoroughly enjoyed it. So the first question, that was the can biologics like Ritux and tocilizumab can be having effect in a patient with coexisting asthma with rheumatological disease?
Yeah. So prior to these biologics, rituximab was used in the treatment of severe asthma, and certainly, in a sense, can play a role. As you know, rituximab blocks B cells. So the theory is if you reduce B cells, you produce not only, you basically suppress Ig production. The one caveat about rituximab is you can actually cause potentially immunodeficiency, and we see that with rituximab. Sometimes B cells are completely suppressed, so the immunoglobulin levels drop, and when the immunoglobulin levels drop, especially IgG, then the patient is at more risk for infection. So that's something that you also have to balance. So while rituximab can help by suppressing Ig, but it also blocks IgG, and so these patients may be more prone to infections.
Thank you, sir. And one more question is that Indians have high IgE level, often found in many of them, like ranging from 1,000 to 2,000. So what to do in such cases?
Yeah, that's why, even though omalizumab is, and you have many biosimilars of omalizumab, I think it's important, not to, well, to two things. So first of all, because you have a high parasitic burden, I think before you, in the context of a high IgE level, you want to make sure that it is not due to a parasite. So what I would do, in the Indian scenario is empirically treat with the course of, however you do it, whichever antiparasitic you have, give a course and then recheck the IgE level, recheck the CBC. Now, if the IgE level is still high, but if the patient clinically doesn't have any symptoms, then there are many causes of high Ig. For example, that have nothing to do with asthma. For example, patients with atopic dermatitis, their Ig levels can be thousands many times. High Ig itself, can be normal. In that scenario, though, I would say, do not utilize omalizumab, because that is going to be, you're going to do a disservice to the patient, right? Because in order to really have an effect, you have to bring down the free Ig level to a level of below 20. So if your baseline Ig is 1,500 or 2,000 as your example, and we know that it's not practical. You can't exceed 375 milligrams every 2 weeks. So in that case, do not dose. That's my that is my recommendation. And then the last thing I would say, in the context of asthma, when you do have a high Ig level, especially also when you also have high blood eosinophil level, then you do have to screen for ABPA. So this is, aspergillus. So we would do a skin test to aspergillus. Or an in vitro blood test to aspergillus. We would also check aspergillus perspitans. You may consider chest CT scan looking for bronchiectasis. So this is one of the things in challenges in India. You do have to, unfortunately, because of high prevalence of ABPA, that also needs to be explored.
Very true, sir. So thanks a lot, sir, for all the guidance. And I think other question we will put to you with the message,
Okay.
and we will get back to all the questioners. So we will send them the answers. It was very nice here, Dr. Kunal. Thanks a lot for inviting me. And Dr. Mehta, it is absolutely nice to hear you, and we enjoyed a lot. Thanks. Thanks a lot.
Thank you. Okay. And so on Friday, I'll try to answer some of these questions, and you'll see that Friday's talk will be shorter, so you'll have more opportunities for interaction.
Thank you so much.
Thank you so much.
Yeah,
Right.
thank you so much.
Thank you.
Thank you for taking the time out, waking up early in the morning to ensure that you're speaking to us, and we thoroughly enjoyed. This was a very nice. So rheumatologists love biologics, and when they listen neurobiologics, we love it more. So thank you so much for teaching us three new biologics today. And I hope
Thank you.
the audiences enjoyed it as much as both me and Dr. Bhagat did. See you on Friday. We'll be waiting with our bated breaths to listen to your
Okay.
biology talk. Thank you so much, sir.
Thank
Thank
you.
you.
Thank you, everyone. Thanks.
Thank you.
Have a nice